Good evening. My name is Rohan Joseph, and I'm the Advocacy Committee Chair for the Florida chapter of the American College of Surgeons. On behalf of the Surgeons of Florida and the Florida Chapter Advocacy Committee, I would like to welcome everyone to the virtual All Florida Surgical Advocacy Day series. A quick housekeeping note to start. We are asking that everyone keep microphones muted while our presentations and while not speaking. In light of COVID-19, we have transitioned our Advocacy Days programming to a series featuring monthly educational programming. All attendees are encouraged to participate in the 4 sessions and share these opportunities with their colleagues, societies, and institutions. I would like to ask Dr. Danielle Hendry, the Florida Chapter Advocacy Committee Vice Chair, to introduce our series.
Thank you, Dr. Joseph. So we're excited to focus on the 2020-2021 Virtual Advocacy Series on effective advocacy for the 2021 Florida legislation session. Over the next 4 sessions, we will discuss being an effective surgeon advocate, the role of the American College of Surgeons, key issues related to surgery, including scope of practice expansion, the impact and role of the hospital system, payers, and institutional government affairs in the legislative process, understanding the legislative process from the perspective of Florida's legislators, and the role of collaboration between Florida's surgical specialty societies. Please be sure to mark your calendars and join us in December for a video, January 14th for a live presentation with Florida legislators, and February 11th for a live presentation with several Florida surgical specialty societies.
Tonight, we will hear a conversation on state advocacy and a wrap-up on the 2020 Florida legislative session and what is likely to come during the 2021 legislative session. The evening will wrap up with 25 minutes for discussion and a Q&A between our presenters and viewers.
We will hold all questions and discussion until after both presentations. Everyone is encouraged to use the Zoom chat feature during the presentations to discuss and record questions. You may also use the raise your hand feature during the discussion and question and answer session to ask a question. Dr. Joseph and I will moderate the discussion and the question and answer session with the speakers based on the questions that you ask, supplemented by several of our own questions for the speakers as necessary.
Now, I would like to introduce our first 2 speakers. Session 1 will feature 2 speakers. The first speaker is Dr. John Armstrong, who is Associate Professor of Surgery and Division Director at the University of South Florida Mersani College of Medicine. He has been a surgeon advocate for over 30 years. He is chair of the ACS Committee on Trauma Advocacy Pillar, a member of the ACS Legislative Committee, and an advisory member of the Surgeons PAC Board of Directors. Dr. Armstrong is the former Florida Surgeon General and Secretary of Health and immediate past president of the Florida chapter of the American College of Surgeons. Our second speaker is Christopher Johnson, who is the manager of state affairs for the American College of Surgeons based in Washington, D.C. Christopher has over 15 years of government relations experience working in the public sector, association sector, and corporate sector for the American Cancer Society, City of Chicago, Walgreens, Chicagoland Chamber of Commerce, and Uber Technologies. Christopher has a master's degree in public policy from DePaul University, Chicago, and an undergraduate degree in political science from Illinois State University. Thank you both for being here tonight.
Hello, Florida surgeons. This is John Armstrong, a trauma surgeon, University of South Florida. And I'm glad to be here with Chris Johnson, who is manager of state affairs for the American College of Surgeons. And we're going to talk about state advocacy, especially to help inspire surgeons to be surgeon advocates. Chris, it's good to see you.
Thank you, Dr. Armstrong. Great to see you too.
So why should we care about advocacy at the state level? There's always a lot of buzz about federal advocacy, but What's the deal with state advocacy, Chris?
Well, I think, I'm biased in my opinion on state advocacy in comparison to federal advocacy. I'm a state person. I've always done state work, government affairs work at the state level, local level, a little bit here and there on the federal level. But state's really where the action is. It's where the real work tends to get done, and it gets done in a very quicker fashion than it would happen on the federal level. I like to rib my my federal colleagues a little bit every so often and remind them that I think that federal advocacy or the legislative process at the federal level is a lot like running a marathon on a treadmill. You do a lot of work, but you're really not going very far, and your victories are co-sponsors rather than bill passages. Now, that's not to say stuff doesn't happen in Congress. It does, and they do pass things occasionally, but at the state level, you really get a lot of work done in a very short period of time, and it's very quick, very fast paced, and very exciting in my opinion. So I think state level is really kind of where it's at. Additionally, I think what's really important about state legislative and state advocacy is that a lot of what you see happen at the federal level starts off in the states. These are the places where the ideas are created. The experiments, what's the term? States are democracies, labs of experimental or whatever. It's where the ideas start, and they eventually make their way to Congress and the federal level. And I think there are plenty of examples where we've seen this. The ACA is a perfect example of that, where it started off in Massachusetts as a model for providing healthcare, and it made its way to the federal level. I think there's several other issues, especially those of which we deal with, which, surprise billing is another example of that. So, states are very cool.
I think you highlight that we actually live in several systems of government. And while it's easy to focus on federal, the state and frankly local systems of government can have even greater impact on us. And particularly when it comes to how we take care of patients. States regulate practice through the Practice Acts, and that's where scope of practice comes in, where we've had some challenges in Florida with non-physicians wanting to expand their scope, and that changes the nature of the quality of care of patients who get referred to us. And then we also have issues with insurance, and insurance is regulated by the states. And we've been working on challenges with prior authorization, as well as out-of-network billing, now called surprise billing. We also have been very focused on protecting credentialing and privileging within the profession and ensuring that maintenance of certification is respected. And then you think about our efforts at disease and injury prevention. We try to prevent cancer, we try to prevent injury. A lot of that is regulated through the legislature by various executive agencies. And finally, we can't forget Stop the Bleed, which is a top priority because it really reflects a way to give something to our communities and to our citizens that will save lives. And so we seek legislative help to disseminate it, to ensure we have kits in the right places. But all of those areas we've been dealing with in Florida.
Yeah, absolutely. And I think you really hit it on. I mean, there's a local flavor that happens with the policy development, and that's why states and even local governments have played such a vital role in public policy. You have to know what's best for the communities and within the state, the needs of the population. And that's why you see a lot of variation in law from state to state. If you ever experience changing your practice setting from one state to another, you know that in one state you're going to have a totally one set of rules in which you practice under, and that can be completely different in a different state. And so there is that knowledge that the states do apply the laws and their policies based on what they consider the needs of their populations.
I'll tell you, Chris, I've been involved in advocacy for over 30 years. Actually goes back to when I was a medical student, when I appreciated that If we as medical students, residents, and physicians didn't get involved in shaping decisions that were best for patients, decisions were going to be made that might forget about the patient altogether. And I've come to appreciate there's a real science to this whole advocacy process. And it's not the same thing we were taught in civics on how a bill becomes a law. It's something that's got some of the more human dimensions to it. How do you look at the legislative process?
Actually, it's funny that you mentioned that it's a science, or there's a sense of a science. There's actually a combination of science and art to it. You have to really understand sort of the nuance, or the what influences the players involved in the legislative process, and identify how you can get your message across to those different groups of people. And what I've found in my experience doing this, and I've done it in various different forms, whether it's I've worked in the corporate setting, I've worked in other not-for-profit setting for patient advocacy, and it's really one of the most compelling ways is to be able to tell a story that appeals to the elected officials and that's relevant to the policy that you're trying to get across. And in a lot of the talks that I give to chapters and to the surgeon members of the chapters in other states, and I might have even touched this on my presentation last year at this meeting, is that you, in your position as a surgeon and in your interactions with patients, you're actually learning what the challenges are facing your patients and facing your ability to practice. And that's where we get our ideas for good public policy. And that's how we can then take those experiences and those examples of what you do every day in your interaction with patients and in the operating room and convey that back to the legislators. The legislators aren't experts in everything. They need to know a little bit about everything, but they rely upon the experts who are doing the day-to-days. And, we're fortunate enough to have in certain legislatures, some physicians that are members of the legislature. But the fact is, some of those might be a family physician, or they might be a specialty surgeon. They're not going to know the nuances of what your interactions are with the patients. And so it's very helpful to be able to share that story. And I think that's really kind of where the art form comes in, is being able to tell the story in a way that appeals to them, to the legislator, on why they should or shouldn't support a piece of legislation. Then there is the scientific aspect and the procedural, which is how do you get a bill out of committee? How do you get a bill introduced, or how do you get it into committee, or how do you defeat it in committee? And then the next step, which is it comes to the floor, and how do you count the votes there to make sure it either passes or gets out or doesn't get out. And then you get into the next chamber. Florida is a bicameral legislature. There is some examples, Nebraska, which only has one chamber, so it's a little bit different. But that's where you have to kind of fit in the scientific approach to, how do we play the process? But then there's the art form of how do you build that relationship and convey the need for the particular position that we have, and that's telling the stories of everyday experiences.
Yeah, that's what I think really drives the legislative process is what's happening to people in the district of a particular representative or senator, how you can make it real so it's relevant to that member of the legislature. There's a certain reality that once somebody's in the legislature, what they want is to stay in the legislature for as long as they can. We have term limits in Florida, 8 years per chamber. But that having been said, a whole lot of interest in meeting constituent needs on face and to get reelected. And so the stories in the end can be grouped to create action through a bill, or the stories can be used to shape the way a member looks at a particular bill as it is relevant in that district.
Yeah, I absolutely agree with that.
And I think that's where it's hard sometimes for surgeons in particular, because we're data driven, and the legislature is really it's really filled with a lot of human emotion and frankly some ambition. And so when we are talking with legislators, we need to understand that frame of reference, and that the anecdote, as we might call it, the story, as a legislator might hear it, is sometimes something that we're a little less comfortable with.
Yeah, and I will discount data as well. I mean, there's certain data points that are very important to a legislative office. Having worked in an office myself, we would look at the number of phone calls or emails that came into our office on a particular issue. And that count, whether it's one side or the other, did weigh in on how important this particular issue was and how much we should be investing in on it, paying closer attention to it. Whether we should be taking a yes position or a no position based on the feedback we're hearing from our constituents. It is important, and that is a key component to the decision-making process. And then followed up with the real life examples, which having sat through numerous committee hearings and floor debates and what have you, legislators like to be able to point to somebody, their constituent, that had this particular experience to justify why they're voting on a particular issue or voting against a particular issue. And again, it's really a nuanced approach to how we do, how advocacy works, being able to present all these this information to them, being able to point it up with engagement and a large number of engagement, whether that's through phone calls or emails, really helps make it easier for an elected official to take the positions that they do.
That engagement piece is so critical, and it's not only meeting legislators in district or in Tallahassee, but it is engaging through emails and through phone calls with so-called calls to action, because as you point out, it's almost like a tick mark tally, for and against, and that can shape the conversation that a legislator is going to have. Also highlights the importance of the staff. What advice do you have for surgeons about working with staff, and not only of the legislators, but of the committees that exist within the legislature?
Oh, no. I mean, again, having been a staff person, they're incredibly important because we're compiling all the information and they're taking in all of the different sides and really kind of helping formulate the final position that would be taken. And, the legislator is being pulled in a lot of different directions. And then they also have their, the election side of things that they're constantly worrying about, because elections tend to happen every 2 years for many spots, unless you're like a senator where you have a couple of year cushion, or 4 years if you're in a larger, a different position, an administrative position. But it's the staff that are really doing the day-to-day interactions with people, day-to-day interactions with constituents, and then the research component to it. So building relationships with the legislator is incredibly important. And I would say, if you have a relationship with your elected officials, that is fantastic. If they're calling you or texting you for a question on something, that's great. If the staff person is also reaching out to you and asking you for clarification on an issue or asking what your opinion is on something, that's just as good, if not better, because that will make its way to the elected official at some point in time when the time comes for them to make that decision. Backing all of that up, those relationships up with the tallies, the check marks, the numbers, that saying, if I had a perfect scenario in where, we had 3 or 4 surgeons have a great relationship with an office, the elected official and their staff, to be able to convey a good story and talk about a particular issue directly with them, and then say, you're going to hear from a number of others that think this is important, and then that hearing is included in phone calls and emails to back up what we just said to them, then you basically have done the best work you can as an advocate. And it's then up to the elected official to make that calculation on how they're going to take their position.
Now, something else I find that we have to remember is that the process that a bill moves through to become law, it's not like, as a surgeon, booking a case for the OR. So the expectation is that the patient will get to the OR. When it comes to a bill, dropping a bill in the proverbial hopper it doesn't mean it's going to go anywhere. It really depends upon how the bill lines up with committee chairs and with the leadership in each chamber. How can we be more effective at seeing that for what it is?
Well, I definitely say work with your local professionals. The Florida chapters are very fortunate to have a lobbyist on contract, and this is somebody who's going to know the best process in which to get a bill moving. It is, again, it's a matter of how it's drafted, and based on that, it will determine which committees it'll go to. And knowing who chairs those committees, who's on those committees, what their jurisdiction is, will help determine how quickly a particular bill will move or not move. And so, and that includes who sponsors the bill. So you have to be very mindful of who you get to sponsor legislation. I mean, that's really, you know, part of working within the organizational structure that the ACS has and the chapters is really critical to being able to be successful and getting legislation done.
So I think what I hear you saying is that some things have to line up to get a bill to move forward, and typically that's going to involve which party's in power, and that's where the sponsor of a bill becomes important. Might be more difficult in the House or the Senate for a bill to move forward if it's being pushed by somebody who's in the opposite party from the party in power. It's a reality. That's how they are structured. A bit more prominent in the House than the Senate. But I think appreciating that there is a lot of frankly power that exists with the leadership in each chamber and with these committee chairs, it shows you where there are some further opportunities or barriers to an issue moving forward. Well, as I hear this as moving to wrap up, it seems that the key issues for effective advocacy involve being informed and staying informed, understand what the process is, and then build and sustain relationships. Do you think that captures the essence?
I think that's a pretty good simplification of the two things that you could do very easily to be engaged in the process. Understand what's going on and what's happening, and then build those relationships.
And I think it's important to appreciate that advocacy, it's a team sport. It can be a contact sport because it does involve scarcity. I think politics is fundamentally about allocation and scarcity. You're allocating scarce dollars, you're allocating, in some respects, scarce rights, you're allocating scarce positions. And so there's going to be, typically in the political process, some friction there.
Yeah.
But when you bring a discipline to the process, staying focused on what you're trying to achieve, along with a sincerity and discretion, so you have trust that you've built up over time with the relationship, you stand a better chance of achieving the advocacy outcome.
And there's a level of, obviously you want to approach it respectfully, but there's a level of patience and persistence that is required. I think when I started, I talked about how state legislation moves much quicker than federal legislation, but there are times where you have to build these relationships, and there's a multi-year process to get something accomplished at the state level. Not a multi-decade process that might happen in DC, but at least a couple years, and you have a clear game plan on how to achieve that and build those relationships. And I also want to stress that what's important with state advocacy and the relationship aspect of things is that the members of Congress, the majority of the members of this particular Congress were originally state legislators or governors. And, when I mentioned where ideas bubble up from the states to the federal level, it's because these individuals are taking their experiences in these issues at the state level with them to DC and then talking about it, which develops into policies there. So if you're building a relationship with somebody, and this includes even the local level, your city council member or alderman or mayor, which can be even easier to get in touch with, these, like I mentioned, these individuals have a in their hopes to a long-term career in politics, which includes getting the next seat, going to the state legislature, which then includes going to DC at some point. And everybody who's in politics at some point looks in the mirror and says, "I'm President so-and-so." So there's definitely a level of that. It doesn't hurt to build these relationships early on.
Well, Chris, I've enjoyed our conversation. Really excited about our advocacy program with all Florida chapters. And thank you so much for your support.
Well, thank you, Dr. Armstrong and Mr. Johnson. That was a great conversation. Next, I would like to introduce Chris Newland of the Law Offices of Christopher L. Newland. Chris Newland is a health lawyer and lobbyist out of Jacksonville, Florida. He has served as legal counsel for both Blue Cross and Blue Shield and the Florida Medical Association. He has provided counsel and lobbying services to Florida specialty societies for 25 years. And most importantly, he has been the Florida chapter lawyer and lobbyist for that entire time.
As I mentioned before, my name is Chris Newland. I'm your lawyer and lobbyist. I'm not always quite this casual as I am in this picture, but I do have to tell you, for purposes of transparency, that I have no disclosures that you need to know about. I work for physicians. That is my clientele. That is who I work for. But I do want to give a word of thanks to a bunch of people. First and foremost, I want to give thanks to the physicians who take their time and effort to work with us on the advocacy team. What you see in front of you is pictures of Ankush Bansal and Jason Goldman, who came to Tallahassee last year in order to lobby on our behalf, and I thank them and all of the physicians who have come throughout not only this year, but all the years, not only to the legislature, but to the regulatory boards that we go to each and every month, arguing on your behalf. I also want to thank the FMA team. While this is a slightly outdated picture, it is in fact a team that we work with. And I especially want to thank Jeff Scott and Mary Thomas, who are the bookends in this picture, who are the FMA legal team, for their help both in the legislature and throughout the regulatory challenges that we've had over the last several years. In 2020, there were two issues in front of the Florida legislature. There was scope of practice, and then there was everything else. Scope of practice was the major event of the 2020 legislative season, and it took a lot of forms. There were physician assistants who were working to expand their scope. There were pharmacists who were looking forward to expanding their scope. There were nurse practitioners looking to expand their scope. And we're not even going to get into the physical therapists and other ancillary providers who want to do more and more all of the time. When it comes to scope of practice, as I said, you have a lot of people out there who want to be doctors, who want to play at being doctors. And they had a receptive ear in the Florida legislature this year, especially in the House of Representatives, where Jose Oliva was insistent on, as he put it, dismantling the healthcare delivery system. And he wanted to make it less reliant upon doctors. What did they want? In each and every instance, our ancillary providers, our physician extenders, wanted independent practice. That meant no inherent limit on the scope of their practices, no limit on the practice settings, in other words, the types of facilities in which they could provide these types of services, and no limit on what they could prescribe and when they could prescribe it. What did they actually get? APRNs under House Bill 607, which was the final vehicle that passed, now may practice primary care as long as they meet the educational requirements, which are in excess of those of normal APRNs, and they may not perform any major surgery. In fact, any surgery they have must be minor and subcutaneous. In other words, they can take off a cyst, something of that nature, but they're not going to be doing transplants. They're not going to be doing elective surgeries of any kind. There's an ongoing debate in the summer months as to what constitutes primary care. The Board of Nursing has a fairly expansive definition of that would allow nurses to treat and prevent disease as part of their primary care mission. We in medicine think that that is expansive, and we are struggling to try and get the Board of Nursing, which unfortunately has final authority on this, to recognize that there are services for which you need to refer a patient to a specialist. And those types of services are in fact not primary care. PAs, they got nothing. And they'll be back this year. We know that they will. But in the last days of session, when the Senate broke down and finally said that they would consider independent practice, they discovered that physician assistants and APRNs do not go through the same type of training, which is ironic since we have been saying for years that APRNs and physicians don't go through the same type of training, and that's the reason there's a differentiation. The Senate, for whatever reason, came to the conclusion that physician assistants, because their training is different than APRNs, should not get the same rights that APRNs were getting. They obviously were not happy, but they will be back next year trying to get the same scope of practice that the ARNPs did receive. But the big winners in all of this were the pharmacists. The pharmacists started the year hoping that they would be able to treat flu. They got a lot more than that. Pharmacists will be allowed to enter into collaborative practice agreements within a facility for what are called chronic health conditions. Chronic health conditions are those conditions that typically last greater than 1 year and are not acute. Examples include hypertension, COPD, asthma, type 2 diabetes, and HIV. Community pharmacists may test and treat for flu, minor infections, athlete's foot, etc. In other words, those type of minor conditions for which a simple antibiotic or something, Tamiflu, something of that nature may be given. They did get the right to test for flu. But we did get one huge win. We went to the Board of Pharmacy when the Board of Pharmacy said that any and all chronic health conditions should be allowed to be treated under a collaborative practice agreement between a physician and a pharmacist. We disagreed on that, and we did it on legal grounds that the legislation that granted the right to have these collaborative practice agreements listed 6 different conditions and said that other conditions could be developed, could be approved by the Board of Pharmacy after consultation with the boards of medicine and osteopathic medicine. We argued that the language of the statute prohibited the Board of Pharmacy from allowing each and every condition to be approved. They must be considered individually, and there may be some expansions for things like heart disease and for some behavioral issues. Those will be coming up over the next few months and will be considered individually, but they did not get the overall expansion to all chronic health conditions that they had originally wanted. A big win for our legal team. So what's going on in 2021? The Florida legislature is going to have a tough year. And while healthcare will always be there, there are 2 issues that are going to dominate the session are going to be the budgeting shortfall because of an economy that did not meet expectations in 2021, because frankly, nobody expected there to be a pandemic of the size that we ended up having. Redistricting. Because of the new census, every House of Representatives district, Florida Senate district, and members of Congress all will have their legislative districts changed. That is always a frightful scene to be. That is always a mess as legislators try and make sure that their district is configured in such a way to maximize their chances of both retaining their district and potentially moving up to the next level. And while those two issues will dominate the session, we will still have our issues. We will continue to press on the insurance reforms that we mentioned. We will continue to try and prevent PAs from obtaining independent practice, although they have told us they will be coming for us. The APRNs want an even greater bill. CRNAs want the ability to practice anesthesia without a physician anesthesiologist. And through all of this, there will be logistical issues. Because of COVID, there will not be the types of physician visitations, the group visitations that we've come to know and love throughout the legislative session. People will only be allowed in the Capitol if they have appointments with legislators. Only one person will be allowed in a legislative office at a time, and yes, they will be checked. That puts the pressure, obviously, on the lobbying corps, who are going to have to make sure that they have appointments and make sure that they are well representing the issues and the interests of the physicians that we serve.
Thank you, Chris. Each of our presenters tonight remain on to participate in discussion and answer your questions. Please use the chat function to post your questions, and Dr. Hendry and I will volley them back and forth to our presenters. I believe Dr. Daubertine asked a question. Is CHF one of those conditions that pharmacists can treat, Chris?
CHF has been proposed as one of the conditions that pharmacists can enter into a collaborative practice agreement with. It has not been approved yet, but they expect sometime in October to have a hearing on that. And based upon previous discussions, if I were to bet, I would say that CHF will be added as one of the qualifying conditions, probably sometime at the end of this year.
Thank you.
All right, great. Dr. Armstrong, you mentioned strategic advocacy during your presentation. How do you do strategic advocacy?
Thanks, Danielle. So what strategic advocacy does is to frame an issue in the broad context of what's happening in the legislature and what the priorities are for the legislature and for, I will use the chapter as the example. And so the first key question is to really clearly define what the issue is. I have found too often that there is not the clarity with the issue right at the start, which means that it's difficult to develop strategies. It's difficult to have coalitions to try and move an issue forward. So it's a process that allows prioritization, and it's a very deliberate way of making sure that we've got the teamwork and the discipline to achieve success on any given issue.
Thank you, Dr. Armstrong. This question is for Chris Johnson. Chris, how much of a certain time should be expected to getting involved in advocacy?
Thank you. It's a good question. You know, advocacy to a certain extent is what I like to consider as a full-time thing. It's participation in, as a citizen. It's knowing what's happening within your government at all levels. It's just being knowledgeable of what's happening, reading the papers, paying attention, not necessarily the politics, but really kind of the stories of what's happening in the legislature, some of the issues that are popping up that you're aware of, as well as speaking with your colleagues and interacting and talking about the issues that you're facing on a sort of how the regulations are impacting your ability to practice. But when you look at engaging, such as tonight, which is an hour, and the future meetings, which are a combined 4 hours, I believe, through the chapter, and then you have, a handful of other meetings. And I would always encourage anybody, once we get into a point where you can go back to the Capitol again, and we go back to the Capitol to meet with legislators, it really isn't that much time when you think about it. There's not a lot of barriers to engagement. It's just a matter of knowing where everything is and easily accessing it. We try to make it as easy as possible for our members to engage their legislators through surgeonsvoice.org, which is our website, which you can find through the FACS website. And through there, you can easily, it takes seconds to send an email to your legislator on an issue. And most of the time, we're going to send you that email to ask you to send the email. So it takes even less effort on your end to engage that way. A meeting with your legislator, literally picking up the phone or sending an email to their office and asking for a few minutes. It's a 30-minute coffee most of the time, or in these days, maybe a 30-minute Zoom call or FaceTime, or however it works best for you and for them. It doesn't take a lot of effort. It's not really hard. And again, they're people just the same as you and me, and they like to talk. That's part of their job, is talking. So, yeah, I think there's a lot of trepidation as far as engaging, because it feels like there's a lot you have to do. There isn't a lot. It doesn't take a lot. It doesn't take a lot of effort to do.
Thank you, Chris.
All right, our next question is for Chris Newland, and this comes from the chat feature. So what about people who will be losing their employee health coverage? Where will they go? Medicaid will get many more enrolled, and the budget will be problematic, and reimbursement doesn't quite cover the costs. Can you speak to that, please?
Absolutely. And this is an issue at the Florida level that obviously Congress is having at the national level. COVID and the economy are inextricably linked at this point. We can't get our economy where we need it unless we get the virus under control. That being said, the two issues that I'm told are the biggest issues coming before the legislature are, what do we do about COVID, both as a disease and also as an economic driver, and B, what do we do with our economy to try and get things back? Where do we go? Medicaid is going to get hit. There's no way around it. And one of the things we're going to have to advocate for is a budget that anticipates an increased number of people on the Medicaid rolls. That, despite the fact that as of last counting, we're about $5 to $6 billion behind in our annual about $80 billion budget. The two don't mix. Now, the good news is in the last 2 months, the Florida economy has picked up better than most people would have expected, and the news may not be quite as dire as we had thought. The other issue that's going to be huge in the legislature this year is going to be redistricting. As you know, every 10 years we have a census, and based upon that, those politicians that Chris and Dr. Armstrong were talking about earlier are going to try and protect their particular districts so they have an easier time getting reelected, or in fact can move to the next level, because the Florida Senate, for instance, has a great deal of influence in determining what the congressional districts will look like that they will be running for. So most of the Florida members of Congress, in fact, have hired their own lobbyists to try and get their districts as favorable as possible. Those are the major issues coming down. Yes, we're going to have scope of practice, but Colleen Burton, who has been named the chair of the House Health and Human Services Committee, has told us point blank that COVID will be the #1 issue, including potentially liability reform for those who are accused of having fostered COVID, including doctors' offices. If someone says that they caught COVID in your office, what type of liability do you have for that? Now, I'm here to tell you as a lawyer that I can defend almost all of those types of cases, just because it's very tough to prove that they caught COVID in your office. But the legislature is thinking about giving you some liability protection there as well. And obviously we would support that. But to go back to Dr. Daubertine's question specifically, yes, Medicaid's going to need more money this year because there are going to be more people on Medicaid until the economy picks up again. And the economy won't pick up again until people get vaccinated and people feel that they can go back to Universal and Disney World and places like that.
Thank you, Chris. Next question is for Dr. Armstrong. Dr. Armstrong, meeting with legislators is often intimidating, and one of the suggestions that came up was to cultivate a relationship, to be engaged. What is the best way to prepare and the best way to maintain influence when talking with legislators?
Well, thank you, Rohan. I think building a relationship starts with just getting to know a person, and it's easy typically to go on the legislator's website and look at the bio and look at committee assignments and what's really important to the legislature. You can glean an awful lot from that information. And then I suggest working to meet with the legislature in district, not in Tallahassee, not during session, at a time when you can offer who you are and that you'd like to help, and not go in with a specific ask, but really make it an opportunity to get to know the legislator and for the legislator to get to know you. If the legislator is not available, meet with staff. Staff are critically important to moving legislation forward, and you can build a relationship with staff that will then build the relationship with the legislator. And I think it's important not to make this like a one-time thing, which I find can often happen. There's one meeting and I did it and I'll get a call. That's not really how it works either. So it's important to do follow-up and to, again, track what's interesting to the legislator, figure out how you can help the legislator achieve his or her goals, consistent, I would hope, with what the chapter is working to achieve. And through that relationship, ultimately get to the point where the legislator is asking you, what do you need? What are you thinking? That tells you you've got something that's going to be very meaningful moving forward.
Thank you for that answer. So this next question comes from the chat feature, and this will go to Chris Newland. With nurse practitioners independently practicing, and we assume this means with no oversight from a physician, are they held to the same standards as physicians from a medical legal perspective? Do they carry malpractice insurance? Are there caps on their damages?
Let me answer the final two questions first, because those are the easy ones. Yes, we ensured that in the legislation, they must carry malpractice insurance, and there are no caps on the damages that can be given to them, although they only have to carry $100,000, $300,000 in malpractice. As to the standard of care, that is for the trial bar to try and figure out over the next couple of years. Although the FMA and us came up with language literally within the last 72 hours that we are proposing to a joint commission of doctors and nurses to be presented next week. I believe it's on the 19th. We'll be arguing for that before the joint commission. If it passes there, and we're optimistic that it will, it goes to the Board of Nursing. If the Board of Nursing opts not to do it, we have every intention, and we being the Florida chapter and the FMA, of going to the legislature and making that part of the Independent Practice Act.
Excellent. Thank you, Chris. This is for Chris Johnson. Chris, what can residents, fellows, medical students do to participate?
Yeah, I say I highly encourage residents and medical students and interns to engage now. And how do you get engaged is, frankly, through your chapter, I think is one of the best places to really start out. The college has some amazing resources and they provide the chapters for engagement. through the chapter and frankly through the National Association as well. But you take, it's using the same suggestions that we have for every fellow of the college, which is how to get engaged. But I think doing it at the beginning of your career is really, really critical, because again, these engaging with the legislators, these are the people that are going to dictate how you practice medicine in the future. And you want to be part of that conversation and help guide what the future of medicine looks like. So getting engaged means basically attending these meetings, attending meetings of the chapter, responding to action alerts, reaching out to your legislators, doing all of the steps that we've talked about this evening. Start that now. Again, I know there's concerns about, how much do I have time to do this? How do I do this? That's what we're here for. We're the resource to do that. Talk to those who've been around for a while. I'm sure Dr. Armstrong would be happy to provide some guidance and some pointers on how to do that engagement. But I do feel very, very strongly that that's the time to do this is right now.
Thank you, Chris.
All right, the next question, Chris Newland. You indicated that a bill becomes law through the legislative process, but rulemaking happens through the relevant boards. What is our role with the boards?
Our role with the boards can be as much as we want to be. Let me give you an example that hits surgeons directly. In 2019, the legislature passed, with our support, a new office surgery legislation that required the facilities in which level 2 and level 3 procedures were done to be registered with the state pursuant to rules to be promulgated by the Board of Medicine, which in fact already had done a bunch of that. But it's the Board of Medicine that determines what drugs you have to have on your crash cart. Several years ago, for instance, there was a requirement that every crash cart must have dantrolene on it, which is a great drug to counteract malignant hyperthermia. But if you're not doing something that could trigger malignant hyperthermia, it's a needless expense. So we went to the boards and we said, if you're not giving succinylcholine, if you're not giving a gas inhalant anesthesia, there's no need to have dantrolene on your cart because you're not having a triggering agent for MA. The board agreed with that and they decided, okay, we're going to take the requirement of dantrolene off the cart if you're not giving one of those triggering agents. That's the kind of thing we do at the board. The board gets into the actual specifics. The board, for instance, are the ones for the plastic surgeons who may be on the call. We had a problem with gluteal fat grafting, and we were able to work with the Board of Medicine over the course of several months and say, listen, we're not going to outlaw gluteal fat grafting, but what we are going to do is say, we will not allow an intra or submuscular injection of the fat into the buttocks, which all the evidence has shown that is where the problem is. If you go above the gluteal fascial muscle, the gluteal fascia, you're usually okay, like in 99.99% of the cases. You can get much more done at the Board of Medicine on these nitpicky stuff than sometimes you can get done at the Board of Medicine. The chapter has been involved. I'm at each and every rules and surgical care committee of the Board of Medicine. And when we have issues there, we go ahead and we fight for our docs. And I know we're running out of time, but there are numerous instances where we've affected policy at the Board of Medicine, even when it looked like we lost at the legislative level.
And with that, I would like to say that we are at the 1 hour mark, and we want to be respectful of everyone's time tonight. Thank you to our presenters, Dr. Armstrong, Chris Newland, Chris Johnson, for your participation and your time this evening.